So the next speaker would be Dr. Lucy.
Good afternoon, everyone. I'm Dr. Lucy Kaveri. I work in Narayana Netralaya, Bangalore. So my topic is short and long-term follow-up of patients, relevance of various investigations. With an extensive overview of preoperative workup, how to do these meticulous calculations, most of my talk is already covered because whatever you do pre-op is something that you would be monitoring post-op to avoid these parameters. So when I joined my fellowship, I discussed it with one of our seniors after looking at their ICL post-op and extremely good results that what should be my investigations once the patient has been done and the 6/6 has been achieved. The answer was very simple, that if your vault and IOP is okay post-operatively, you just forget about it. And that's the thing. With what extensive workup Dr. Hema Malini and Dr. Aishwarya has shown you, if you have done your homework prior to the surgery, you can forget about the patient. Patient will be happy as long as the cataract, natural cataract develops. But still, to go ahead, what exactly is short-term follow-up? Now, this definition varies for different people. For some, it would short-term would be say a week, 10 days, a month after the surgery, or for some it would be 6 months after the surgery, because ICL surgery when done in early 20s would be giving patient at least 20-25 years of spectacle free life. So long-term follow-up again is till the time patient develops presbyopia or age-related cataract. Now looking in short-term follow-up, once the patient has been operated, in the immediate post-operative period, what all parameters should be looking into. The first and the earliest key to any abnormality is the visual acuity. Visual acuity on the first day post-op would let you know whether there was any too much of surgical manipulation, and if that was the case, it would something which would settle down easy. It would also let you know if there is high intraocular pressure. In cases of toric phakic IOLs, whether there is any rotation, undercorrection or overcorrection done. Next to this is a good slit lamp evaluation, which will help you determine any of the earlier suspicion that visual acuity had arisen. On slit lamp evaluation also, if there is epithelial edema, then the next thing that you would suspect would be high intraocular pressure. This intraocular pressure in the immediate postoperative period could be because of the retained viscoelastic and inadequate wash after implanting the ICL, but it could also be a reason of it could also be due to high postoperative vault, which Dr. Hema Malini had shown earlier, and known that in the immediate postoperative period, if the vault is very high with ACD less, then it is one of the indicator to exchange the ICL, go back and see where your calculation went wrong, whether there was any sizing issue, and if it is due to sizing issue, then probably doing an early ICL exchange is the key. Similar would be the thing for a very low vault, because in long-term follow-up, this would lead to cataract as we saw earlier. And the next important assessment, the investigation that has to be done is probably the vault assessment. With the current generation, there are plethora of devices available. It could be either anterior segment OCT, or it could be one of the topographers which are based on Scheimpflug or OCT based topographers, which would give you which would give you an objective value of the vault. However, slit lamp assessment still holds true as the best one to evaluate vault. These investigations need to be followed up for the long term, because we saw that when the vault over time it decreases. Some people have said that it continues to decrease over 3 months of time, and couple of studies have said that it continues to decrease over 6 months of time. So most cases where the vault is borderline high with a good anterior chamber depth, we tend to leave the patient assuming that over next 3 months or 6 months the vault would come down, but that doesn't happen all the time. Even with the modern ICLs or IPCLs, where there is a central hole or peripheral hole available, if you leave this high vault for longer duration of time without assessing the angle, there are chances of angle closure happening. So this was one case done with IPCL, where despite the fact that 6 holes were present, patient developed angle closure, and in the lower image you can see after doing the PI, the vault had come down. Other than angle closure, the most common type of glaucoma in the immediate period is the steroid responsive glaucoma or pupillary block glaucoma, and there have been multiple case reports of pigment dispersion glaucoma either due to manipulation of the surgery where the pigment dispersion is lot more, or general tendency of high myopic patients to go ahead with pigment dispersion. Hence, gonioscopy in your follow-up period becomes one of the important investigation. Despite so many advances and newer models of phakic IOLs coming in picture, the vision outcome has improved. But the recent report says surgeons are still afraid of the cataract formation, because once that is developed, the patient loses the natural crystalline lens which is there. So there have been multiple meta-analysis, and Dr. Hima has already covered the pathogenesis of how cataract develops. But then why to wait for such a stage where the cataract is already developed? When you are doing a cosmetic surgery, it is a good idea to document the patient's density, lens densitometry, from the preoperative period and each follow-up visit, so that when the lens density changes are beginning, you can counsel and educate the patient regarding the same. So in order to document these density changes, there's a tool available on Pentacam where, based on Scheimpflug densitometry, it also gives you the Pentacam nuclear staging, where it determines stages from 1 to 5, where 1 would be the earliest density changes. You can also move the cursor to each level of the lens to see where exactly the density is increasing. One more new tool is available with iTrace, Tracy Surgicals, where it gives you the dysfunctional lens index. Now this dysfunctional lens index is a combination of internal aberration, lens density changes, and pupil size measurement. So even not just for lens density changes, it is also useful as a follow-up tool for ICL patients where they complain of loss of contrast sensitivity or glare or halos, where you can get a simulated E-chart and teach your patients that where exactly this problem is arising from. Doing the cosmetic ICL surgery doesn't stop there. We need to remember that we had done this surgery in a patient who had high myopia. So each follow-up visit should be followed up with a dilated detailed fundus evaluation, because the retinal detachment rate after phakic IOL is same as what it would be in a high myope. It doesn't alter it. So again, screening for peripheral degenerations has to be the same. Specular microscopy studies have shown that there is not much change in specular microscopy over long run, especially after introduction of the phakic IOLs with the central hole. However, some amount of change has been seen in the periphery, and those cases where a PI has been done, the peripheral changes in the endothelial morphology as well as the number quantitatively has decreased. One investigation which we do in our keratorefractive procedures but probably miss out on our phakic IOL patient is the biometry. A pre-op biometry is done, but this would be better to be repeated post-operatively as well, because certain cases where you operate ICLs at say early 20s, 21, 22, there are chances of axial myopia developing even after that. So rather than counseling the patient that or just answering them that the surgery is not working anymore, it would be easier if there is documented biometry report. So to summarize, it is best to do whatever investigations you have done pre-operatively. The same needs to be repeated post-operatively for the patient as well. Special emphasis needs to be given on the walt, angle assessment, lens changes, fundus evaluation, counseling the patient at each level. You don't need to have any of the fancy instruments to document this. Even a good slit lamp evaluation and giving a good chair time to the patient would be enough. So to end, I would like to invite you all for a cataract and refractive conference that we would be having in April in Bangalore. Please block your dates and visit us for the same. Thank you. If you have any questions for any of the speakers, we have time to take that.